110 so far, and that gives me great thrill and excitement. This gives me great thrill and excitement that when I look at the amount of knowledge database that we have built, almost 450 hours, and about 1,500 people who have come and spoken at these webinars, because we have had many of them in a panel format also. Well, as a brief introduction, Foundation for Economic Growth, or EGROW Foundation as we normally call it, was incorporated in October 2018, and we started with a vision of research-based policy advice to the government and to any other institution that would demand research from us. When COVID set in, we changed our course and we said, this is a time when everybody now has internet. We need to tap the best brains from across the world to talk about issues, both global and domestic. And we've been very fortunate that we have had a blend of scholars from India, Indians working abroad, as well as foreign scholars on issues which are both relevant for India and have importance for rest of the world. That blend has been very, very beautiful, and we feel very fortunate that we have been able to maintain that blend. 6 Nobel laureates have already spoken at this forum. Under the G20 presidency of India, we did 21 webinars, 11 on new international economic order, 6 on women empowerment, and 5 on climate. That's not the end of it. We have been following these topics over a period of time. As there was a change in regime in the US and the tariffs became important, we have had 6 webinars on tariffs and economic growth. And in none of these 6 were Indians there, because we wanted to get a picture of what's happening in the rest of the world and how they interpret the tariffs. So this was just as an illustration that EGROW Foundation is trying to harness knowledge from across the world on topics that are both relevant for India and for the globe, and from the best minds that are available. The EGROW Foundation is very much aware of what is happening on various issues within the world and the country, especially developing countries. It is now being flagged in most of the international publications of public policy that health issues are extremely important. If you need an efficient and productive workforce, obviously, labor has to be highly productive. We have invited Professor Federica, Angeli, for delivering this talk today. We've been trying to get her for quite a bit of time. Professor, if you remember.
I know. I was hoping you didn't. But...
And many things were happening at your end.
I know.
And we are blocked till end of May already. So to get a slot for you also, we had to juggle in. And finally, we are lucky that there's a mutually acceptable date. And today is, we are going to listen to her. To chair the session, we have Dr. Rattan Chand. Dr. Rattan Chand is the founder director of EGROW Foundation, a dear friend. He's been with the Ministry of Health and Family Welfare for nearly 3 decades. He has worked at the senior-most level in these ministries. He has been a consultant to the World Bank post-retirement, and he has been also a consultant to Niti Aayog. He has worked extensively on health-related issues, especially on women and female health-related issues, and we have requested him to chair the session today. With this brief introduction of the think tank and the chair of the session, I invite Dr. Rattan to take over.
Thank you, Dr. Chairman. Let me welcome, first of all, Professor Federica and also other distinguished participants. Mute कर दीजिए. So let me introduce briefly about Professor Federica. Professor joined the School for Business and Society as Professor in Management in September 2019. Prior to that, she was Associate Professor in Global Management of Social Issues at the Department of Organization Studies at Tilburg Universities. Federica also held positions at Maastricht University and at the Indian Institute of Management, Bangalore. Federica graduated from the University of Bologna, where she obtained a BSc and MSc in Industrial Engineering and a PhD in Management in 2009. Her research focuses on organizational adaptations and learning to address complex societal issues with a particular focus on inclusive healthcare delivery, poverty alleviation, and societal resilience. Federica is a member of the Royal Society of Arts, Manufacturing and Commerce of the Academy of Management, Social Issues in Management, and European Group of Organization Studies. She also serves as academic editor for PLOS 1. Since 2015, she has convened a conference subtract at the yearly colloquium, a reflect of contemporary challenges facing healthcare organizations. I think we will listen to her and we will be benefited by your presentation. So over to you, Professor Federica.
Thank you very much. Thank you very much, everyone. I'm really, really honored to be here. And I'm sorry it took me so long to actually fix the slot and fix the presentation. And, you know, sometimes life gets in between of, you know, nice things that one wants to do. Now, let me share my presentation. So what I will be talking about today is indeed, let me see. Can you see my screen? Can you see my screen? I hope so.
Yes. Yes, we can see.
Brilliant, thank you, because I can't see anything else anymore. So, well, so today thank you first of all for the introduction. And as I said, I'm really honored to be here, and I'm really honored to be able to talk to you this morning about a topic that is really close to my heart and to my research, underpins everything that I've been doing so far. And so the title of the talk this morning is Tackling Global Health Inequity Through Health Enhancing Innovation in Resource-Constrained Settings. So as Dr. Chan very nicely said in his introduction, I'm Professor Federica Angeli. I'm from Italy. And although I traveled quite a bit now, and I settled in the UK, I've been working at the University of York as a chair in public management and strategy, and also now also as a deputy dean in strategy and people for the School for Business and Society. Now, the School for Business and Society is quite an interesting and different reality in the realm of business schools, because it combines businesses, business studies, management studies, with a really strong focus and a really strong, let's say, mission to tackle global challenges and to, you know, to make really an impact on the pressing problems of society currently in the world. Now, thank you for the introduction, because we can skip this slide entirely. So as Dr. Chan mentioned, so I'm an industrial engineer. I got my PhD from the University of Bologna, which is where I come from, really. And over time, it was, sometimes career path serendipitous entirely. So I sort of ended up studying healthcare organizations, healthcare strategies, healthcare policy, but with a particular focus on India, at least, in the initial part of my career, because I was lucky enough to visit the Indian Institute of Management, Bangalore, in 2007, 2008. I spent 1 year in Bangalore working with the NSCREL, which is the Entrepreneurship Center. At that point, I was studying, networks and interorganizational networks, so interorganizational collaboration, which is something that is really close and is really foundational of what I do today. However, I think my visit to India sort of changed something. It was quite a defining professional and personal experience for me. After that, I was a postdoc at the Maastricht University India Institute, which was an institute specifically devoted to gather all the interest across the university, across Maastricht, in India and for India. So that's how I started. That's how I developed this interest in global health, in global challenges, and generally speaking, and also in poverty alleviation and its interaction, in its interplay with health and with global health. Now, first of all, because this talk is about health inequity and health inequalities, and we hear a lot about health inequality, health inequities, and oftentimes they are used interchangeably. But what is actually health inequity? And is that the same thing as health inequality? This was a point that I thought was foundational for me to make in this talk today. Now, actually, the World Health Organization defines equity as the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. But what does that actually mean? So this is one of my favorite visuals about inequity, inequality, and the difference between the two. Now, in the first quadrant, the left high side, you can see, a little boy, two little boys or two little girls trying to catch an apple. And obviously, because of how the tree is tilted, one little boy gets the apple and the other little boy doesn't get the apple by sheer chance, because how the tree is made and because of where the little boy is standing. So there is nothing between them that justifies or explains the differences. It's just sheer chance. It's just a matter of position, and it's just a matter of how the tree is tilted. Now, this is the inequality part. Now, so it's an equal access to opportunity. Now, if we consider equality, now equality means providing the people who have unequal access to opportunities with the same kind of tools and the same kind of support and the very same kind of resources. However, if we provide the very same thing, this inherently doesn't take into account the peculiar and specific idiosyncratic disadvantage that these people are facing, which is not necessarily the same. And in fact, if we do that, you see immediately in the picture underneath, the equality picture, that we provide the same ladder of the same height, but then one little boy gets the apple directly from, or little girl gets the apple directly from the tree, but the other one still can't reach because it's further away in terms of where he or she is positioned. Now, gaining equity, realizing equity and pursuing equity means that we understand the specific disadvantage that groups and people are facing because of where they're born, when they grow up, where they live, because of the family they have grown, born within, because of their parents' education, because of all these aspects. It means that we understand their specific disadvantage and we tailor support and resources accordingly. So we give them ladders of different heights, and that's where equity is realized. So you see, equity and inequality are extremely fundamentally different concepts, in some sense, even polar opposite to some extent. Now, realizing justice from this point of view would be redressing the root cause of the inequality. So would be, straightening the tree from this point of view. And at that point, if the tree is straight, then it makes sense to give ladders of the same height. Now, so health inequities are systematic differences in health outcomes that arise because of the social conditions where people are born, where people age, where people work, and so on and so forth. Now, maternal mortality is a key indicator of health inequity. So, I think you mentioned before, Dr. Singh, that Dr. Chad is, and I've also studied quite a lot the situation of women, and particularly in terms of maternal mortality, and together with a PhD student from India, from PGIMER in India, she evaluated the National Rural Health Mission and its effect on maternal and child mortality and morbidity. And for example, what we have seen is that vaccination rates did go up for children, so immunization improved. However, for example, aspects such as antenatal checkups and maternal mortality did not significantly change before and after the introduction of the policy. And this goes down to the very specific and idiosyncratic barriers that women face when having to take up antenatal checkups that we know are fundamental to identify high-risk pregnancies and to reduce maternal mortality and morbidity related to childbirth. That is why maternal mortality is a key indicator of health inequity. It shows the wide gaps between the rich and the poor, and both between and within countries. It is shocking that nearly 830 women die every day due to complications during pregnancy and childbirth, with roughly 550 women who live in sub-Saharan Africa, 180 live in Southern Asia, compared to only 8 in high-income countries. So, by the same measure, every day 16,000 children die before their 5th birthday, and they die of pneumonia, malaria, diarrhea, and other diseases. And they are 14 times more likely to die, that's again shocking, before the age of 5 in sub-Saharan Africa than the rest of the world. Now, by the same measure again, another indicator that really is a stark indication of differences and of socioeconomic differences within and across countries is life expectancy, which varies by 34 years between countries. As you can see here, a child born in Sierra Leone can expect to live 50 years, while a child born in Japan can expect to live 84 years. Now, is this just a problem of the differences between global north and global south? Not really. So there has been a change in mindset, if you think about it, between the Millennium Development Goals and the Sustainable Development Goals. Now, the Millennium Development Goals were really focused on, problems that were specific to the global south, that were specific to low-income countries, and there was sort of a focus on averages rather than on variances, and so on averages rather than inequalities. Now, the Sustainable Development Goals, including, maternal health, including gender equality, and so on, are much more focused on those inequalities that plague not only the global south, but also, by the same measure, the global north. Health inequities are stark and rising within countries. For example, in the United States of America, African Americans represent only about 13% of the population, but account for almost half of the new HIV infections. And there is absolutely no biological or genetic reasons for these alarming differences in health. Now, coming to where I live, well, I don't live in Glasgow, but I do live in the UK. It is stark to see the statistics about children living in poverty. only 17,000 in the city of Glasgow. We're talking about 18%, 6,000 in Blackpool, 25,000, which is a 27% in Manchester. And they are particularly in the north rather than in the south. So you can see, for example, Hampshire, only 9% of children live in poverty. Now in Glasgow, male life expectancy ranges from 66 years in Rochdale, which is one of the poorest neighborhoods, to 81.7 years in Cathcart. Now, another statistic that is often cited is the one around London. If you travel east from Westminster, each tube stop represents nearly 1 year of life expectancy lost, according to the findings of the London Health Observatory. So health inequalities are an issue, but why are there such an issue? What are the consequences of health inequity and health inequalities? For example, tuberculosis, we know, is a disease of poverty. Around 95% of tuberculosis deaths are in the developing world. 87% of premature deaths from non-communicable diseases are in low-middle income countries. Healthcare costs for NCDs can quickly drain household resources, driving families into poverty. The exorbitant cost of non-communicable diseases, think about cancer, think about diabetes, think about obesity, think about chronic respiratory diseases, are forcing millions of people into poverty annually, stifling development. As Dr. Singh mentioned before, this is taking a huge toll on economic development and on households, so individually, on communities, but also really at national level. We need a healthy workforce. And how can we achieve that? Persistent inequity slows development of health and well-being, but also on sustainable cities and communities. And it's a huge financial burden. So the European Parliament has estimated that losses linked to health inequity cost around 1.4% of gross domestic product within the European Union, a figure that is almost as high as the EU defense spending. This arises from losses in productivity and tax payment, but also from higher welfare payment and healthcare costs that then the government has to pay out to people in need and to finance, for example, the NHS in the case of the UK. So now we talked about health inequity, and hopefully I made the point about what health inequity is and what are the strong and very, very significant consequences from a financial point of view, from a societal point of view. It's a moral imperative, but it's also an economic need to tackle health inequity. Now, what are the causes? Interestingly and sadly, in a sense, there are so many low-hanging fruits that could be plucked and would dramatically improve global health and would dramatically reduce these health inequities. What I always cite is the study by Banerjee and Duflo, who won Nobel Prizes for Economic Sciences in 2019. They wrote an absolutely brilliant book that is called Poor Economics. I'm sure you're aware of it. And they use really experimental methods to study poverty within resource-constrained community. And for example, what are these low-hanging fruits? They are really inexpensive solutions to many of the problems that we have seen cause maternal death, cause child mortality, and cause all kinds of morbidity around the world in resource-constrained community and in low-income countries. But why people and communities do not take them up? That's a big question. For example, malaria bed nets in sub-Saharan Africa, they are often used. People do not understand the need for those, do not understand the potential benefit. They are often used as wedding veils, oftentimes, or toilets, to prevent open defecations and the related epidemics and the related health consequences of those. ORS and chlorine to reduce diarrhea and disinfect water. They are just sachets that they are even provided for free in many settings to women to prevent diarrhea in the children, but oftentimes they don't use it. Breastfeeding, this is a big thing that we also see here in high-income countries. More and more women decide not to breastfeed despite campaigns. And despite it being really proven to be really what is best for children. Immunization, we saw that during the COVID-19 pandemic and most recently, and the whole no vax movement and so on and so forth. Improved cooking stoves, family planning, and so on and so forth. So why is it so difficult to implement this solution in some settings, not just in low-income countries, but all over the world? Of the 9 million children who die before their 5th birthday each year, the vast majority are poor children from South Asia and Sub-Saharan Africa, and roughly 1 in 5 dies of diarrhea. Efforts are underway to develop and distribute a vaccine, the virus responsible for many of the cases of diarrhea. But 3 miracle drugs could already save most of the children, the ones we talked about. Dehydration is the main proxy cause of deaths from diarrhea, and ORS, which is close to being free, is a wonderfully effective way to prevent it. However, the lack of demand for these and the lack of uptake underscores perhaps the most fundamental difficulty of the problem of health, and why also these health inequities are persistent despite the Millennium Development Goals, despite the Sustainable Development Goals. The ladders to get out of the poverty trap exist, but are not always in the right place, and people do not seem to know how to step onto them or even want to do so. And why is that the case? Well, again, the root causes of health inequity and the lack of demand for inexpensive products that could really improve dramatically and disproportionately the situation of many, they root back to the social determinants of health, which are linked to where people are born, grow, live, work, and age. So you see here that determining individual behaviors and also individual uptake is a number of factors and multiple levels of analysis. Individual lifestyle factors, social and community networks, living and working conditions, so work environment, education, food and agriculture, unemployment, water and sanitation, healthcare services, housing, and the general social, economic, cultural and environmental conditions. So maternal health, health inequity, but also, for example, obesity, these are all wicked problems that are rooted in an interplay, a complex interaction of many different factors and many different levels of analysis. And that's why it is they are so difficult to eradicate and to tackle. Health inequity, again, are unfair and avoidable and could be reduced by the right mix of government policies that aim at modifying individual behavior. An example of policy, in the case, for example, of obesity in the UK, is, introducing a sugar tax, is banning fast food from, deprived communities, banning fast food from schools, develop, free meals plans for schools that also, impart that type of nutrition education that children need and families need, and so on and so forth. So, in terms of, it's important also to understand that there is a health, that's the trap that Banerjee and Duflo were talking about. It's a health-related poverty trap, because poor health co-evolves with poverty at population, individual, and intergenerational level. You see the poverty trap here at population level. You have low income, which leads to lower levels of education and healthcare, which leads to low levels of human capital, low productivity, and again, low income. On the other side, low income leads at household level to low saving, low investment, low economic growth, and again, low income. So there's a development element and a growth element. At the same time, poverty leads to delayed healthcare treatment, which leads to catastrophic healthcare expenditure, which again leads to poverty, which leads to poor health, lower capability to work and study, and again to poverty at individual level. Unfortunately, this also extends also at intergenerational level. So children who are born into the private environment won't get the necessary education, parent support, and socialization, which leads to poor consequences and poor health outcomes and poor education outcomes in adolescence, adulthood, old age, and again perpetrated to their own children. So it is a wicked problem also in the way it extends from individual to community to population and also to the next generation. Now, coming now to the research that we have conducted. Now, research in slums it's been extremely interesting because it has shown that gendered and socioeconomic differences in how slum dwellers perceive health, disclose health issues, and seek treatment. Now, in particular, we looked at three main elements. We looked at the self-construction of health meanings, and we discovered actually with a number of semi-structured interviews that have been carried out by my PhD student Mumita Das, now quite a long time ago, but she did an incredibly thorough and robust study in the slums of Kolkata and Delhi, if I remember correctly, or was it Kolkata and Kolkata and Bangalore, I think. So she discovered how health is understood in the realm of physical, psychological, spiritual, religious, cultural practices, and geographical location. So when do slum dwellers, how do slum dwellers perceive health? What are the situations in which they decide to disclose a health problem? And when do they disclose a health problem? Who do they disclose it to? And which type of healthcare do they seek? These are all fundamental questions to understand whether and how and why they seek and also they receive the best possible healthcare treatment that they should and need to receive. So first of all, the health meaning are really deeply influenced by all kinds of religion and cultural practices. So for example, as you see a few quotes here, someone said, "We understand health are happy from inside, but when I see many women here being beaten by their drunk husband, I feel though they show happiness, they are sad from inside. And when you're distressed from inside, you're not healthy." We don't go any far away public toilets at night because it's not safe for a woman to go out alone at night. And the one which is very close to our slums remains closed at night. This is very uncomfortable and we are not happy with such arrangements. So it's a combination really between, here we see gender, we see family situation and family dynamics, we see domestic violence, but we also see how the natural and built environment and the community and the facilities do influence individual choices that influence directly health outcomes. Another point, as I mentioned, is illness disclosure choices, which is again an outcome of a complex nexus of gender, type of illness, marital status, type of confidant, type of providers. There is stigma attached to disclose illness, and there are significant family constraints, especially for women. Whenever we all men folk gather in the evenings, women and men though, whenever we all men folk gather in the evening, we discuss everything right from poverty, politics, problems in the family and workplace, but everyone is conscious not to discuss about one's health problem. No one can reveal, or no one reveals health problems, and this is the only place where men can flaunt one's manhood and vigor. Now, another point is provider choice. Once it is closed, once it is recognized, and who do they seek healthcare from? Public healthcare infrastructure are often poor or perceived as such. So what they do, what we found they tend to do, is to delay the treatment which is a problem because then it becomes obviously more serious and potentially more expensive, and they decide then to go private. Formal allopathic healthcare service is seen as the last resort, especially for women, though they tend to prefer traditional healers. This study specifically looked at how the social cultural sustainability of private healthcare providers in an Indian slum setting again. And we have found that there is quite a strong preference for private over public healthcare providers, which is, however, a problem because obviously there is financial costs attached to it, which can push family into poverty, which can determine catastrophic expenditures. But there is this sort of aspirational demand for private healthcare, which is something, again, that the government could change through a right mix of health literacy, health education, good campaigning that support, public healthcare providers, and obviously through funding. Now, another interesting study that we carried out was in the city of Ahmedabad. Now, we looked at the determinants of health provider choices in urban slums through a discrete choice experiment. Now, this is a really interesting method because it is easy to administer. It is sort of a survey where respondents have to choose between different scenarios. It could be a private provider versus a public provider. It could be a traditional provider versus more modern, let's say, allopathic sort of medicine type of provider. You can choose providers of different distances, with different level of appropriateness, different level of quality of care or familiarity and so on. So it's quite easily administered, and it allows to for gathering quite interesting insights. What we found interestingly, though, in this specific setting, among these specific respondents, is that the preference of private versus public provider was not so strong. And also the preference of a traditional instead of a public provider was not so strong at sample level, at population level. Now, this changes when we look at, when we interact this aspect with demographic, for example, age, gender of women, and so on. I think in the case of women, there was a preference of traditional instead of public providers, but at population level, at least, it was not significant. Instead, you see that the most important attribute for people in choosing healthcare providers was the appropriateness of care. So public policies could really pick this finding up to understand and underline that what slum dwellers need, at least according to these findings, is providers that are known to provide, good care. It doesn't matter whether they're traditional versus not, or private versus not. Also, an important attribute was the familiarity and the attitude of the doctor, whether it was a known doctor instead of an unknown doctor. That is also very, very important because of an element of, comfort and familiarity and trust. Another important element is trust. And also the attitude, friendliness versus an indifferent attitude. And from other studies, we found that this was particularly relevant for women and for the social aspect of disclosing health problems and finding a solution to them. Now, what are the solutions? Because, so far we talked about the causes and we talked about the incredible differences and heterogeneity attached to health. Health is not, there is an enormous, if you think about it, there is an enormous asymmetry of knowledge between the patients, between the people who are ill and the people who provide healthcare. And this is very important because health literacy is crucial. Most people, especially in deprived settings, do not see the link between potential solution and the difficulties they experience from a health point of view. There is one citation, one quote that I always use, and we were in a project about improving cooking stoves, again in the slums of Bangalore. And so the research team was carrying out some qualitative research among women who were, of course, cooking with traditional methods, and which were creating quite a lot of indoor pollution, which was a clear determinant of respiratory problems for these women. And at some point, someone asked from the research team, someone asked a woman, they said, why do you think you're coughing? And her response, she said, because I'm a woman. I'm coughing because I'm a woman. Because for her, it was just a fact of life. It was just typical of her, of what she was experiencing. Because all of the women who were cooking with, the very same methods in the very same settings were all coughing. So, and she didn't realize, obviously, she didn't have the education or no one ever told her that the problem is the tools that she was using to cook and the smoke that these were creating. So this is a very important aspect, the importance of health literacy. Now, what are the solutions? We carried out a number of studies on that, and I will present you briefly the differences between organizational innovation and technological innovation to tackle global health inequity. Now, appropriate business models could be a solution. Now, in this specific study, we looked at inclusive business model for health delivery. Now, a business model is essentially a template that portrays how organization creates, delivers, and captures value. And it's made of value proposition, value creation, and value appropriation. So the proposition is what you're offering to the customers. Value creation is how you mobilize internal and external value chain resources that create and deliver value. And value appropriation are ways through which part of the value created flows back to the organization. Now, we looked at, in this study, already from 2016, so 10 years ago, we looked at very famous studies that are, all obviously from India, most typically Aravind Eye Care, Narayana Budalayana, GE Healthcare, Vatsalya, Sulabh, and the 1298 ambulance service. What we found, interestingly, is that obviously they can all go down to the traditional distinction between value proposition, value appropriation, and value creation. However, what they all shared was a really crucial stage before the value proposition of value discovery, which involved organizational efforts to increase awareness, patient recognition, which involved the key processes from the organizations that could foster patient recognition of a health need and a co-identification of a socially acceptable solution. I remember most typically the Aravind Eye Care, they do eye camps, they go out in the countryside, in rural areas, and they diagnose patients there and then. They organize buses then to bring patients back to the hospital with their community around them. They explain, so there is a really strong and important and salient effort of education for this patient. And this is key. The value discovery aspect is absolutely key to all these business models. So essentially, and in a sense, this is also typical to, for example, to maternity care. And this specific study looks at, which has been published just last year, looks at research on maternity care to vulnerable pregnant women in the UK. And here we see the importance of an intersectional socio-ecological mindset. So, and again, we are back to maternity care. Whether the women, vulnerable women specifically, decide to take up antenatal checkups and to engage with the process of, maternity care depends really from, and we can look at it from a social ecological model, which is the one that you see on the right, depends really on a complex interaction between individual factors such as education, gender, age, homelessness, socioeconomic status, ethnicity, migration, and employment, but also at the community level. So the first layer, family and community support, norms and value. On an organizational point of view, so organizational model and professional practices that deliver care. From a governance policy and governance modes point of view, and also again, from the natural and built environment. Now, this model was particularly interesting for me to study because this specific midwifery group decided out of just organically, bottom up, to create a completely different model of maternity care and of antenatal care. So they decided, first of all, to go for, and they specifically cater. So this is a specialized midwifery group in Leeds, where I live, that specifically caters to vulnerable women, defined, for example, as asylum seekers, people from ethnic minorities, people who are refugees, and so on and so forth, people who are homeless, women who are homeless, and couldn't access the mainstream healthcare system otherwise. So what they do is, first of all, they do home visitations, for example, through which they can pick up on clues, for example, of human trafficking. Some of these women were not even aware that they were being trafficked. This is something that has been picked up by the midwives during their work, their midwifery work. So they conceive vulnerability as a unique lived experience. They have developed with the women a holistic and trust-based relationship. They are able to liaise with a number of agencies outside police, but also all kinds of charities that can provide women with emotional support, but also with antenatal classes, but also with baby products and so on and so forth. So they are able to activate a specific network of agencies around each and every woman. And through that, they manage to develop this entirely new, bespoke, need-based care model. Now, this was the slide that I was looking for before. So this is again back, sorry, I mixed up the slides. This is again back to the business model innovation and the case of Aravind Eye Care and Narayana Budalayana. So essentially, part of their business model was really, the key point was engaging base of the pyramid patients and community. So patients and community for low income settings. They leverage local human resources for health and suppliers of innovative medical technology. And through that, they could pursue low-cost care through cross-subsidization and economies of scale. But the key point is, again, the value discovery and the engagement of patients and community, pretty much actually, as the previous example of the midwifery group was doing with their women. The starting point is always understanding what they need. Right, so this is instead a research, the last two studies that I wanted to present to you. This is a research on menstrual health management in India. Again, a study that has been published in 2022 on Social Science and Medicine, shows that traditional products, if properly designed, distributed, and with proper health education, are superior and more culturally acceptable. Now, we all know that menstrual health management is a huge problem. Is a huge problem from, well, appropriate menstrual health management is a huge problem for women and girls who, if unable to properly manage, their periods, tend to or could lose days of work, so can lose livelihood, and girls oftentimes lose days of school because they feel uncomfortable and because they don't have access to proper products to feel comfortable in specifically those days. Comfort that also extends to the possibility of dispose of those products in a way that is, culturally acceptable and appropriate. Now, interestingly, again, we used a sociological lens to map the individual characteristics with the product characteristics. And again, we used a discrete choice experiment to look into these aspects. Now, interestingly, what we found, and that was counterintuitive for us, and this is This is co-authored with, as all these studies, is co-authored with Indian co-authors who are on site, and particularly with Professor Anand Kumar Jaishwal from the Indian Institute of Management, Ahmedabad, which is a long-standing, co-author and collaborator and friend. What we found is that the environmental impact of the product was the one most important attribute that women were using to justify their preferences from menstrual health products. So it is most important for them that the product has a positive or non-negative environmental impact. What does that mean? That plastic-based pads that are widespread in Western countries do not seem appropriate or acceptable in these settings. They are used to, for example, cloths. They are used to reusable products. So product design and product campaigning should go in this sense rather than imposing Western-based or Western-born type of products to manage menstrual health. Right, one last study that we are currently developing, so I'm actually quite, just looking at time, I'm actually quite excited to be able to sort of briefly talk about it today, looks at technological innovation and particularly medical device innovation for, again, to tackle global inequity and global health inequity and to foster positive health outcomes in, again, resource-constrained setting or low-income countries. Now, emerging countries innovation, as well as medical device innovation, has been looked at from many different lenses. As you can see here, they talked about frugal innovation, cost-saving innovation, good enough innovation, reverse innovation, with a number of capabilities such as bricolage or jugaad, which I'm probably mispronouncing. However, what is missing from the literature, it seems, is a really in-depth understanding of how emerging, local indigenous firms develop innovation for emerging countries. So in this case, for Indian settings. Really, and because so far this literature has focused mainly on multinational corporations. Instead, we need to understand how the mechanisms that they use to develop and diffuse this innovation, and especially in the case of health enhancing technology, where we know that there is non-consumption, widespread non-consumption, because people just don't know there are solutions and don't often perceive that health problem as a problem. So the research question underpinning this study is, how do Indian medical device providers develop and diffuse disruptive medical device innovations among non-consumers, thereby promoting market creation? So they don't just have to produce new products, but they also have to create an entire new market. So how do they do that? It was very interesting. We developed a comparative case study in nephrology, chronic kidney diseases, digital eye imaging, prosthetics, and cardiovascular diseases. Now, we cannot disclose the name of the companies. However, they are quite well known in the Indian setting, and of different, some were founded in the 90s, some are more recent, and so, as I said, chronic kidney disease, prosthetic limbs, digital eye imaging, and ophthalmic consumables, so eye products. What we found, interestingly, is that these companies had 6 main mechanisms. First of all, as you can see here, in terms of context, there is non-consumption. There are institutional voids in terms of low IP protection, but also low, not as developed credit institution. There's also low health literacy, as we mentioned, fragmented healthcare delivery, but also inherently a B2, B2C market structure, because it's a triadic market, if you want. You have the providers of medical devices, you have the physicians and the healthcare providers, and you've got the patients. And there are these dynamics and these ties and these relations that had to go all those ways. And also patients have to be, so physicians have to be convinced of the value of the product, but also patients have to be convinced of the benefit they can derive from the products. And we know that it's the case of India. It's mostly out-of-pocket expenditures that, then finance this treatment. So unsurprisingly, all these companies develop immersive need finding. So innovation originated in immersive engagement with patient environment. Founder described formative encounters that revealed the lived consequences of non-consumption. So one senior executive recalled that he saw that one of the patients were crying, he was not able to buy medicines for his wife, and that what moved him beyond the point. Then they have these agile problem cycles. With the knee joint that was featured in 2009, there have been 9 changes made to the same design. So, fail early, fail fast. Technology leapfrogging and adaptation. Despite resource constraint, the firms pursue technologically advanced solution. And as CEO noted, we were not tied to old platform. We could directly build what was best for our context. Importantly, they all do this multi-stakeholder reconciliation because the innovation requires balancing, as we mentioned, hospital, physicians, and patients. One product lead stated, if you satisfy only one, then the product fails. You have to satisfy all of that at the same time. Design decisions therefore reflected clinical requirements, infrastructure realities, cultural practices simultaneously. Then they developed this. So far is how they design and develop new products. And then how do they diffuse and create new markets? Trust scaffolding is one element. So certification and clinical validation function as trust scaffolds. But also, and for me most interestingly, is the ecosystem constructions. So firm constructed ecosystem involving hospital, university, government agencies, NGOs. A founder emphasized the problem is too big for one company, and we need to build a treatment ecosystem. And even more interestingly for me is that they had a completely different perception of competition. There is nothing like, one said, there is nothing like competition because the market is very, very big. So the product innovation starts from the fact that, okay, am I competing with Alpha? So another company in the same market. I'm not competing with Alpha. I'm in the same space as Alpha. So we are all, it's a success if there is one more competitor, because it means that the organization is actually succeeding in creating a market for it. And it's absolutely fascinating. And that gives really the idea of how these problems are systemic problems, going back to, the root cause of global health inequity. It has systemic problems that require systemic solution, and really enlightened entrepreneurs and business people that see this point and develop their business accordingly. Well, that was all from my side. So thank you very much. And if you have any questions, I'm happy to take them.
Thank you, Professor Federica, for your excellent and illuminating presentation. You have covered a vast area, including regulation, different aspects of equity, studies, data, solutions, etc. So I think the listeners will benefit from your presentation. I think we don't have much time, but there are few questions we can take, and the participants can ask questions directly also. But 2 questions I have got on the chat. So first question is, Professor Angeli, how do you see the withdrawal of United States from global healthcare issues impacting primary healthcare, maternal care, especially in developing nations like India?
Yes, so this is the first question that I'm seeing here. Yeah, it's I mean, what is happening obviously in the United States, and you know, the withdrawal from the World Health Organization and so on, it's obviously dramatic. And however, it might give an opportunity for other you know, organizations and other foundations to actually step in and again filling that institutional void. I know for a fact that, you know, the withdrawal of the United States has, you know, I had a friend and a close collaborator working for the World Health Organization at the time when the United States announced their withdrawal. And she was telling me that, you know, contracts were immediately seized, programs were immediately seized. So it has had a dramatic effect. At the same time, I'm thinking, you know, there are several institutions and actors and at global level that might be able to intervene, and hopefully the consequences will not be as dramatic. But yes, it's tragic what has happened.
Okay. So another question is from Mr. Ayandu. He's saying,
Thank you very much. If I may,
just a minute. In India, a major section of the population perceives health based on their social functions. So it is very much possible that they will resort to in their local practices. What are your suggestions on this?
Yes, and this is actually what you know, what emerged very, very clearly from our studies. So especially, you know, there is a gendered element to that, and especially we saw that especially women, they tend to disclose to people very close to them, but they also tend to prefer traditional healers, community based, you know, healthcare providers and healthcare infrastructures. From my point of view, and I think that's also something that was introduced with the National Rural Health Mission, it is extremely important to embed solution and develop. So it's a bundled solution in a sense. So first, you need to increase the level of health literacy. You need to increase the level of health education. But you can do that only with community-based solutions. So community-based, for example, nurses and people who are trusted, but at the same time who have the opportunity to have direct access from within the community. That's the only way to create. There needs to be policies and governmental intervention to reduce the distance between communities, which can be, you know, urban in case of slums, but also rural, and healthcare providers who are qualified to provide, to diagnose and provide the necessary treatment. So I think, you know, I'm not saying anything new here, but I think the route to that is community-based interventions.
Okay, somebody was asking question. They can... No? Okay, one more question from the chat.
Yes, I already sent in the chat my questions. Since I'm leading a course in entrepreneurship and innovation in the context of healthcare management. So my question maybe seems short, but I understand that it's not easy to answer, but just how Professor Angeli see the implementation of entrepreneurial approach in solving health care issues. I have in mind even social entrepreneurship in that context.
Yes, absolutely. Absolutely. We have studied, well, first of all, I did publish a book that is that is called Entrepreneurship in Healthcare. And it's quite, so we did quite study at quite an extent entrepreneurial approaches to health. Social entrepreneurship is fundamental, and some of those, well, from that point of view, all those aspects that have all those cases I was mentioning before, so having like Narayana Rudalayala and so on, they can all be classified as social enterprises. And the key aspect of social enterprises is the combination of social mission with a commercially viable formula. I was, privileged enough to actually talk to Dr. Shetty, the founder of Narayana Rudalayala. And I remember him saying, charity is not scalable. So you do need commercially viable formulas. You do need, otherwise you're always tied to donations and to approaches that are not viable and commercially sustainable over time. So social entrepreneurship is fundamental. And there are many, many examples of incredibly successful social enterprises in this space. And what we see is that particularly social enterprises born out local setting and local environment are the way to go, because they have the contextual knowledge, they have the local drive to actually tackle this problem with solutions that are commercially viable on the one side, because they will know the local suppliers, they will know the local opportunities, they will have privileged access to local workforce, but at the same time they will be able to devise solutions that are socially acceptable, which is again is fundamental to these to tackle these problems in a way that is effective and in a way that ensures uptake by the patients and by the people who actually need these products and these solutions. So thank you for the question. It's extremely relevant.
Thank you very much. I see you are familiar also with the context of Indian. We are partnering with LJ University in Ahmedabad, so they are going to open a hospital. Maybe it's not so big in the scale of India, but 300 beds are quite much if comparing. And the purpose is to combine the training of nurses and doctors. I think they're one of their sections, faculties, with providing again symbolic payments, healthcare services, and that's also a social initiative, outreach.
Absolutely.
Social outreach. Yes.
Absolutely, it's brilliant, and so it's a mindset shift in a way. So it's a different paradigm, because social enterprises, and specifically social enterprise in the healthcare context, they need to have a completely different perspective about what success looks like. Just as I was mentioning the last slide, the fact itself that a market is created for specific health enhancing technologies and products is already a success, even if you're losing customers to your competitor. So it means that there is awareness and there is the sensibility that you need to tackle those problems and to develop an ecosystem that includes entrepreneurs, includes suppliers, and includes motivated workforce, and includes educated patients, newly educated patients that are able to take up those products. So the ecosystem perspective is really crucial there.
Thank you very much.
Good evening. I have a question too. Please, may I ask?
Yes.
I wanted to know, Professor, that what do we see in the area of senior care, elderly care? Do we see health inequality there as well, or health inequity there as well? And does it make a difference whether, again, the financial, do they have a financial status, whether they're poor or they're rich? Does that add to them getting the right health care?
That's a very, very key question. And it's so I didn't study specifically, that field and that, subgroup of healthcare delivery. But what I can say is that, first of all, elderly care is even more than, because, we talked about the social determinants of health. And we also talked about, so that means that inherently healthcare delivery and the way it benefits patients is very much influenced by cultural norms and social norms. So elderly care, for example, is very different across countries, how it is, dealt with, how it is delivered, and also what is found acceptable. So, for example, I'm thinking, I'm Italian. I know quite well the Indian context. But I live and work in the UK, and I lived and work in the Netherlands. Just all these 4 countries have very different perspectives of what is acceptable in terms of elderly care. So in the north of Europe, it's quite common to, have elderly care. So to send the elderly to care homes, which anyway, they are not covered by the national healthcare system. So they come at a huge cost. So definitely we see inequity there, because the families and the communities who can afford those type of facilities then, are able to provide better care to their elderly, but those who can't then rely more on governmental schemes, and inherently there is a difference in health outcomes. However, in other countries, I can say in Italy, but it might be the same in India, it's still families that take care of the elderly, and then there's a huge toll in terms of informal carers, who are not recognized and not rewarded, but who take all the toll of elderly care within families, with also consequences for their livelihood, for their mental health, and so on, and with all these sunken costs that are not seen. And again, there would be inequalities because some families can afford that, some other families can't. I'm not sure I'm responding to your questions.
Oh, thank very much, Professor Federica. With this, we close the questions. But before we close the session, I will request Professor Chesney to say a few words.
Thank you.
Yeah, I want to thank Dr. Rattan for chairing this very important session. Also want to thank you, Professor Federica, for finally making it and delivering this survey-based research with us. I have myself been at IIM Bangalore, and the areas that you are referring in your research quite familiar, and understand the type of research that you have done so extensively. Thank you so much for sharing all that with us. I also was wondering, and I don't know if you want to respond, how do you think AI is going to change this, the what you're calling as the health inequity status? Most of us are anticipating that AI will help us make healthcare more easily available across the spectrum, and therefore income inequalities and other factors would be nullified because of AI. Any thoughts on that before I make my closing observations?
Thank you, Dr. Singh. I think this is, and again, a really, really, really crucial question. And there's many ways to look at that, I think. On the one side, AI makes healthcare diagnosis, obviously, at reach for everyone. I think we all have ChatGPT some health issues that we might have, and understand and try and reduce the asymmetry of knowledge between us as patients and doctors and as providers. However, we need to bear in mind, and again, I'm cautious here because research is still unfolding in this domain, but we need to bear in mind that preliminary findings in this field have highlighted that AI in healthcare, in terms of diagnostics specifically, could potentially exacerbate inequalities and inequities, simply because AI algorithms learn on the data, so they are as good as the data that we input into them. So in a sense, so for example, there was an example from the NHS really, and at some point it became clear that AI was perpetrating some sort of inequalities and mistakes that were made in the past. For example, in the diagnosis of jaundice. So the algorithm wasn't able to detect jaundice in darker skin colors, because what they have learned from the past, what they've learned from the current data sets was essentially mainly white based, and the findings and the outcomes were based on white people. The same applies to gender. So many times AI can perpetrate gender-based inequalities simply because all the findings and all the data sets that the algorithms are learning from are based on, mostly male respondents. So we need to be very careful in, interpreting. There's other domains, for example, breast cancer screening, where AI seems to be much more accurate than doctors. So again, can AI replace doctors, or can AI replace workforce? I think at this point, what research is telling us is that it can have a role in augmenting what doctors can do and who doctors can reach, which is very, very important, very good. We always need to be extremely careful not to, use AI in a way that exacerbates rather than reducing equity.
Thank you so much, Professor. We are hoping that to a great extent in our own country, AI will help us. And I know we'll have to be very careful how it gets implemented. Now, I also want to thank the participants in today's webinar, having contributed significantly in enhancing the quality of discussion that we have had so far. This week is momentous for us. Tomorrow, we are having a discussion on fiscal policy and Viksit Bharat. Viksit Bharat, for my friends from abroad, advanced India. And Costaden, you've been at Bangalore, we have met there. Viksit is what we are chasing now, how to leapfrog India to a different stage of growth. We are on a per capita income of less than 3,000 USD, and we are aiming that by 2047, 100 years of independence, we should touch around 17,000 USD. So tomorrow we have a special session on fiscal policy and Viksit Bharat, because our budget is coming up on February 1. On January 14, we have another session. Again, we are looking at Manrega. Manrega is unemployment scheme for the rural laborers. So we are going to be looking at that on Wednesday. And on Friday, which is our standard spot for webinars, we are looking at artificial intelligence. And Michael Fabinger is going to be speaking to us on AI. And of course, I'm going to ask him the same question, Professor Federica, that how is AI going to help us in our country reduce the gap between the rich and the poor, the haves and have-nots. And as you showed in your very first picture of a tree and saying, look, there is so much of inequity because the tree is tilting somewhere and the other side of the population is not able to avail it. So we are exploring this. So I would request each one of you to kindly pencil it, watch our website, and then please join us. Today's discussion, a very beautiful discussion on health issues, and the way Professor has covered women's health will be on our website by tomorrow noon. If any one of you want to see it again or forward it to someone else, we are more than happy. You can easily do that. With that, let me wish you all a great weekend. Look forward to seeing some of you tomorrow, some of you on 14th, and certainly some of you on 16th for the AI session. Thank you so much, Professor Federica. Lovely
Thank you
to
very
see
much,
you,
everyone.
Lovely to see you, Costaden. After a long time,
Thank you.
You look so relaxed and happy.
I'm planning also to visit India in May, the end of May in Bangalore again.
Oh, I'll be there too.
Oh.
You're coming for the same conference?
Yes, not
Professor
100%
Bala,
decided.
yeah.
Yes, he invited
Professor,
me.
yeah, I'm also there for all that we look forward to. Hi.
Thank you.
Thank
Thank
you.
you.
Thank you very much.